Good afternoon, and welcome to the virtual town hall for October 16th. Thank you for joining us. Today we'll be discussing operational planning for a possible COVID-19 surge, family care solutions, and the current work of the Anti-Racism Oversight Committee. We'll have time for questions and answers, so please submit any questions now or as we go along into the chat box. First, I'd like to provide a few updates. Last month, we introduced our updated mission, vision, and values, and I want to emphasize the importance of sharing these with our teams. To really prioritize our core values and improve our culture, each month we'll be focusing on one value in particular, and this month it's caring. We'll be asking you to share with us and your teams how we see caring demonstrated at Michigan Medicine. I encourage you to please recognize your teammates and give positive feedback when you see these acts of kindness and caring, which are so frequent in our organization. One of the examples of this core value is a recent story that made history, the separation of conjoined twins. Let's watch a brief video of this amazing story.
What's your date, Shine Girls? Okay.
Those are going to do so good. Yes, you are.
Twins are separated.
Sister. Yeah. Maybe I'll go get a posy.
A posy. Yeah, yes. Because we're strong girls. Yeah, and it makes you tougher. Huh? It's just a posy. Good calling. Not the cannula. Thank you. Thank you. Sister yours.
Sister Lisa.
Isn't that an amazing story? And I can only hold in awe and thank everybody who was involved in this amazing surgery and the care and support of these infants and those who documented the story. It shows us at our best, and we reach our best in many different ways, at the highest complexity and at the lowest complexity. And we all do that, and we should recognize all of us who do those things. Next, I'd like to provide a brief financial update for the first quarter of FY21. The first set of bars is the total year FY20, so that ended June 30th, with budget in yellow versus actual dollars in blue. And as you know, we fell short by about $200 million. The middle set of bars shows the FY21 full year budget in yellow and current forecast in blue. The third set of bars shows the first quarter performance in FY21, so that's July, August, and September. Forecast in yellow and actual performance in blue. As you can see, we are trending well ahead of the plan for this year due to the work of many of you, the long hours, the coordination, and the care that you've provided. and hopefully that will continue for the remainder of this year. Many of you are aware that David Spollinger will be stepping down from his role as UMHS president at the end of the year. Dave has been a truly outstanding leader for us over many, many years, including in his role as UMHS president. We're currently holding a search process to find a replacement and have conducted interviews with both internal and external candidates and expect to have more news for you in the coming months. We are also in the planning stages for a search for the Executive Vice Dean for Academic Affairs, and more information will be shared once we have done more detailed planning. Finally, I'd like to provide a brief update on our research enterprise. We've increased our wet bench research to 60% of capacity. The criteria for Tier 3 projects, which are considered higher risk, can be loosened so that we can offer Tier 2 projects that can then resume. We're also welcoming undergraduate students back into the labs at the discretion of their PIs. Now I'd like to turn it over to Dave Spollinger for an update on operations and COVID-19 preparedness.
Thank you, Marshall. I just want, if you haven't seen today's New York Times, you'll know that they estimated that on Tuesday of this week, we had 52,000 new cases, and we're headed for a third peak, one being in the middle of July and of course in the spring. And we've seen across the state of Michigan an increase in hospitalization, and this is the most recent data that I have from October 13th. And you can see that there's been a significant rise in hospitalizations over the last several weeks, beginning about the mid-September. Though the rate has gone down a little bit this past week, it still is somewhat alarming to see the rise in cases going forward. Next slide. This just shows you the different regions, and unlike what we saw in the spring, actually the majority of the hospitalizations are outside southeastern Michigan. Though you can see region 2 North and 2 South has still the highest number of cases, but the biggest growth has actually been in the Flint, Saginaw, southwestern Michigan, as well as in the Grand Rapids area, where they've seen the rate of growth being the greatest. Next slide. And you can see in ICUs, we see also a big increase in the ICUs over the last several weeks. And as of October 10th, there was 227 ICU patients in the state of Michigan. If you go to the next slide, the reason that we're seeing a rise in ICU patients is we're also seeing a rise in the rates of COVID disease in the 70 plus age group. It's now highest that it's been since May. There is a little bit of a downturn the last couple of days, but I do think, remember this, we are concerned about this trend. It's interesting that Washtenaw County seems to be at odds with the rest of the state, and that 80% of the cases here in our area have been in the under 30 age group, which won't drive as many hospitalizations. Today, we had 23 patients in the hospital, and you know, for most of the summer, we were in the, 10 or under, 12 or under. It's only been in the last week and a half or week that we've begun to see it creep up around 20. We still only have 5 in the ICU, and most of our planning that we've had going forward has been predicated on ICU beds being taken up by COVID. So if we get to a point where we're starting to inch up towards 20 ICU or 15 to 20 ICU beds, then we have a plan that we will begin implementing to try and utilize first the D wing, and then eventually, as we get above the 20 to 30, we will probably have to activate the RICU. We've presented this plan previously, so I'm not going to go into it today, but I will say that we are thinking about it each day, and we have triggers which may require us to activate the command center again. Finally, next slide. Finally, I just wanted to talk a little bit about Supreme Court decision. Obviously, The decision that declared the governor's executive orders as unconstitutional, we all had some concerns that there would be multiple different guidelines across the state, and we would be facing patients coming from different counties that had different requirements. That is not turning out, that is not what's happening. Practical implications are really minimal because even though the Supreme Court declared use of the Emergency Powers Act from 1945 as unconstitutional on the governor, there is in place laws that allows the Michigan Department of Health and Human Services to issue requirements based on a law that was passed in 1918 for the pandemic at that time. And so most of those orders are pretty much what has been in place for the last several months. We also have one other, yesterday or maybe 2 days ago, MIOSHA also issued a number of safety guidelines for all employees. And we are working our way through this, but it appears to be pretty much similar to what we've been doing all along and pretty much similar to the governor's executive orders. So I think we won't see much in the way of this affecting our operations. It is possible for counties to provide guidelines that are stricter than the state, but not less strict than the state. So I think that we are prepared for the next surge. We hope it'll be a plateau and not a huge surge, but we are monitoring things on a daily basis. Next, I'd like to introduce Brian Zink, who's he's the Senior Associate Dean for Faculty and Faculty Development, but now is the Interim Executive Vice Dean for Academic Affairs, taking over for Carol Bradford.
Thank you, Dr. Smallinger. Good afternoon, everyone, and thanks for joining us today. I'm happy to share an update on our Family Care Task Force, specifically regarding our proposed solutions. And I want to thank Amanda Thatcher, the co-chair of the task force, and Melissa Dorfman, our project manager, and the rest of the task force members from across Michigan Medicine for the great work they did, spending lots of volunteer hours in this important area. So our Family Care Task Force launched in late July, and in the past 12 weeks or so, we've been working hard to understand the challenges facing our workforce in order to propose and implement some meaningful solutions. Our work began, as you might remember from our previous presentations, with a current state assessment, both of the University of Michigan and the greater community in terms of the resources available for family care. We also conducted peer benchmarking, both locally and nationally, to see what other places were doing. And then we launched both a needs assessment survey and focus groups, where you described the challenges of trying to balance work and home in the middle of this pandemic. The assessment survey had over 6,000 responses, and our focus groups gathered information from over 70 members across job families. The task force then identified 30 potential solutions out of our group meant to address these issues and barriers that we were finding. We realized 30 was probably too many and whittled down the list to 15 potentially doable solutions, which we presented to the Michigan Medicine leadership in the past couple weeks. Today, I'm pleased to share with you a subset of those solutions which are ready for rollout. Next slide, please. So as we develop these solutions and we saw how many of us are living with these complex family care challenges, whether it's preschool and daycare or the virtual school for school-aged kids, or dependent care for adults or older adults in our homes. Our task force went through these ideas, but we had 3 goals with each of the solutions we came up with. One was flexibility. We heard loud and clear that when we communicate with you, the importance of flexibility. Secondly, we wanted to provide meaningful support through all the tactics we were using. And this is an opportunity for us to put our Michigan Medicine value of caring, which Dr. Runge just talked about, into action. And finally, we wanted our solutions to offer more consistency with clear criteria and clear communication and equitable access for the solutions that we arrived at. Next slide, please. So these are the solutions that we are implementing now, and I'll go through them briefly. So the first is flexible and off-hour work schedules and arrangements. We want to provide continued opportunities for flexible and off-hour scheduling solutions at the local level for both patient and non-patient facing work. We've been really pleased to see that Michigan Medicine is already doing this in many units, and we want all of our leaders and managers to talk to their staff about how flexible schedules could help with family care issues. Second, we want to continue remote work arrangements. Initially, we had the approval at the university level to go to January, or the end of calendar year, January 1. That was the date, but we feel confident that we will not be asking those of you who are working remotely to return to work in January. It's safe to assume that if you are working remotely now, that you'll be able to continue to do so through at least March of 2021, and we'll update you as this evolves from the university. The next solution was related to virtual clinics and providers. This has been one of the great adaptive changes that Michigan Medicine was able to accomplish in the middle of this pandemic. We're recommending that we maximize use of virtual clinics, all virtual providers, and a combination of virtual and live clinic partnerships and teams to meet our patients' needs. Next is targeted hiring to expand capacity. We're recommending to allow for proactive need-based hiring in areas with critical needs and shortages. We're pleased to report that this is already ongoing in all clinical and patient support areas. We're using recruiting tools to find a robust applicant pool for areas that are projected to be vulnerable to short and long-term staffing shortages. Human Resources is actively reviewing these areas, looking at turnover and trying to reduce the loss of employees. Next, COVID-19 surveillance testing. We've heard from providers that caregivers are hesitant to work with our healthcare workers due to the risk of COVID-19 exposure. So we recommend providing a mechanism for faculty, staff, and learners to participate in surveillance testing, which is available through the university and is not being utilized to full capacity at this time. We would encourage any of you who might be interested in participating in the surveillance testing to sign up for that. We will also soon have a fact sheet for home caregivers that summarizes our procedures to protect workers and provides data and puts the risk into perspective. We think that you having this document to take to your caregivers will help to reassure them who care for you or who care for your family members that you are protected at work and that COVID-19 testing is rapidly done when it's indicated and that we follow the CDC and state infection control standards. Next is the enhanced expert support to navigate benefits and policies. We understand that navigating all the information on family care is really difficult, and we're working with Human Resources to increase the awareness of the benefits available to the workforce and the individuals available to help us understand these benefits. So we hope for improvements in that area. Next is a comprehensive resources website where we've launched a resources webpage that lives on our Wellness Office website. We're working to expand that page and improve the overall user friendliness and experience with that site. It's not on the slide here, but if you just go to the Michigan Medicine website and the Wellness Office, on the left side of that, you'll see a selection for COVID-19 Wellbeing Help Center. And under that, the family care needs are listed and lots of resources there for you to check out. And finally, the communication part of this is really important, and we want to reinforce some regular communications that are going to be consistent and system-wide with our communication strategy. And we hope that you will be receiving more clear and regular communications in this realm. Next slide, please. So what I just presented is a subset of our proposed solutions. The remaining solutions are under active discussion and planning for a number of reasons. Number one, they're complicated to implement, and we need to work across Michigan Medicine for some of these things, and it'll take a while to get the systems in place to be able to deliver these solutions. Number two, some of them require funds and resources at a time when we're still in economic recovery. So we have to think very carefully about how we can budget for these solutions that cost money. And thirdly, in some cases, we need to coordinate with the greater university, as they might actually be responsible for approving and implementing the solution. This has to do with human resources and benefits issues. So we look forward to providing an update during next month's town hall regarding additional approved solutions. And just want to thank everyone who served on the task force again, as well as all of you who helped shape this work through your engagement in the needs assessment and our focus groups. We are impressed with the creativity, flexibility, and resilience that everyone is showing in these hard times. We've collectively learned a lot, and we appreciate your patience as we try to get some of these ideas into action. So thank you, and go Blue. And next, I want to introduce Phyllis Blackman, who's the Administrative Director of the Office of Health, Equity, and Inclusion.
Thank you, Dr. Zink, and it is my pleasure to speak to you today and tell you a little bit about the Anti-Racism Oversight Committee. We have been working on this throughout the summer, and I am pleased to bring you up to date to where we are. Next slide, please. So first, I'd like to tell you about the Anti-Racism Oversight operational structure. This committee is sponsored by our executive leaders, Drs. Runge and Dr. Zink and Mr. Tony Denton. And they help to set the vision and the overall strategic direction to eliminate racism and inequities at Michigan Medicine. They help to provide, to remove the barriers and to provide the resources that may be necessary to move forward. We also have a leadership level of sponsors, sponsored by Dr. David Brown, Dr. Steve Kunkel, Sonia Jacobs, and Dee Hunt. And I might also mention that this is the same structure that we use for the DEI Steering Committee. And so when we have alignment, it helps to move the, share the resources and to move the initiatives forward. We have our oversight committee structure, and we were very intentional to be inclusive of all the units and departments representation for this committee, because it is necessary for us to hear the concerns that exist in individual departments. We also, I'll tell a little bit more about the priorities that we have, but we are also informed by our resource groups. We continue to form these resource groups each month, and I encourage you to be involved in the resource groups to help to inform our strategic direction. Next slide, please. This is a brief overview of the committee. So this committee was instituted in response to the Racial Discrimination and Social Unrest Survey and the concerns that were presented by the Black Medical Student Association and the White Coats for Black Lives. So this committee, the co-chairs for the committee are myself and Dr. David Miller, the Chief Clinical Officer of University Hospital and CDC. And the committee is comprised of a wide group of people, which consists of leadership, faculty, staff, nursing, and learners, with the charge to implement sustainable measure that addresses anti-racism priorities. Next slide, please. The charge for our committee is to identify the practices that contribute to racism and discrimination and recommend the changes that may be necessary in Michigan medicine. We want to identify an approach that achieves an anti-racist culture and utilize our existing dashboard to track the progress and the outcomes of our work. We also are to develop and recommend a plan around the contributions we can and must make to eliminate racism and the inequities that may exist today at Michigan Medicine. Next slide, please. So our subcommittees have been hard at work, and I just want to thank them for coming together and the work that they have done. This is in addition to their existing work, but the passion and the interest that these groups have it just brings joy to my heart to see the work that's being done. So in June of 2020, we launched the Racial Discrimination and Social Unrest Survey, and we heard the voices, over 1,000 responses from Michigan medicine community. And both the social unrest survey themes and the student concerns led to the formation of these subcommittees. And these subcommittees are the Speak Up and Show Solidarity, Opportunities for Conversation, Education and Training, Diversify the Workforce, Community Work, Advocacy, and Professional Development. And as I said, these groups have been working tirelessly to pull together the recommendations. There are 2 co-chairs for each of the subcommittees, and the committee members, along with some project management support, helps to keep us on track with the work that we are doing. Next slide, please. So throughout the work that the committees have been doing, they've been able to share with Dr. Miller and myself some of the emerging themes. And we found that some of the themes are overlapping and that there is existing work that is already taking place at this institution, not only at Michigan Medicine, but with our partners on Central Campus. So we do have a head start on many of the activities here. So our training and education was one of the top things that arose throughout the conversations, and the opportunity for reporting and to know, what does reporting mean? Who do you report to? Recruitment, retention, advancement, our community partnerships and the work that we are doing there and the work that needs to be done in our community, and the changes that we need to make in our clinical practices, as well as identifying the metrics to monitor the work that we are doing and to make sure that we can see the impact of the work that we are doing. Next slide, please. So we have a very tight timeline, and we knew that from the beginning, but this group was really geared up to help to meet this timeline. And again, I am thankful for the work that the committees are doing. So we have completed phase 1, and we are now in the midst of phase 2. We will begin to identify the subcommittee goals, objectives, and deliverables. That work is already going forth, and we'll be able to have another discussion next week, and to develop the measures of the impact of the work that we are doing. We are on track to be able to finalize and present an action plan and develop and implement the communication strategies along with that. So we are targeting the end of November as the end of phase 3, and I'm confident that we will be able to meet those deadlines. Next slide, please. I thank you for your time and interest, and now I would turn this over to Keith Dickey.
Thank you, Phyllis. So we'll begin the question and answer portion. We have quite a few questions that have come into through the chat. And before I go to specific questions, let me just say a couple things. One, I think a number of people thought, as we were moving questions out of the queue into the dismissed column, please understand that we are not dismissing any questions, nor are we avoiding any questions. That's just our mechanism for moving them out of the chat into our question queue, so we can try to bundle them a bit as we bring speakers back on to answer questions. So please rest assured, we are diligently working to answer each and every question, no matter how tough, pointed, or not. And then the second thing I'll say, I did see a number of comments. It looks like at least a few people thought that the slides were blurry today, and I think that indeed may be true, and we'll circle back with our technology folks to determine why that may have been. So again, thank you all for your questions. Let me start, let's see here, with Dave Spollinger, if we could start with a couple questions for you. Dave can come back on.
I'm on.
Oh, okay, apologies, I can't. My screen doesn't quite see everybody. Let's see here. So first question, Dave, do you have a projected date when the bridge from parking to Mott Hospital will open for employees and visitors, since the weather will be getting bad soon?
Yeah, I do not have that. I will get back to you on that, but I don't know that.
And here's another question that may or may not be in your bailiwick. Somebody's asking, is Michigan medicine staff providing any direct support to local school systems to support them in safely reopening public schools, particularly for the youth most at risk to fall behind during virtual learning?
You know, I'm not aware that we are, no.
Let's see here. Sorry, bear with me. We had a question about COVID. Let's see.
About reinfection.
Yes, about reinfection.
Yeah,
sorry.
so I think that there's been a couple reports of people getting reinfected. It hasn't been the rule. I don't know that we know how long people will be immune. You know, you can get flu several times. There has been some mutation of the coronavirus, though to date, we haven't seen significant mutations like we see in influenza or other HIV or other viruses. So I would say we're playing it safe. So I guess if you've had it and you've recovered, I mean, I think your risk is relatively low, but I still think, you know, it's better to protect yourself until we know more about this virus in the long run.
Thank you, Dave. I'll almost certainly be coming back to you. Thank you for that. Let me turn to Dee Hunt. Dee, if we have a number of benefit-related questions.
I'm on, Keith.
Okay, very good. Thank you, because I actually can't see folks as they come back on. First, the COVID-19 EFLMA is ending at the end of the calendar year, 12/31, but we're clearly still going to have issues with COVID-19 into 2021. What plans are in place to accommodate working parents or people who have elder care needs as we approach 2021?
Well, as Brian said earlier, we are looking at extending the work from home, remote working into the end of the first quarter at least. So you have that option. And those who still have COVID PTO time or PTO time can also use that time when needed. But you will still, if you're working remotely, you still will be able to work remotely for the first quarter at least.
Thank you, Dee. And then sort of the opposite side of the same issue, we have a question. For those of us who do not have to worry about childcare and are deemed non-essential, why can't we return to our departments? And this particular individual noted that he or she is much less efficient working from home.
Oh, I'm sorry about that, but what we're looking at is not just whether or not you don't have those childcare issues or dependent care issues. We're trying to keep our employees safe, and we're trying to keep them from coming into work and being on the Hill and having those patient caregivers as well as the patients in on site.
Very good. Another question, Dee. If we are using targeted hiring to expand capacity, does that mean we're bringing back some people who were casualties of the RIF process?
You know, unfortunately, we did have to RIF several of our employees. So far, we've brought in returned over 150 employees. Now, we've contacted many more than 150, but some of them had secured other opportunities, so we weren't able to get them back. We continue to look at that list and the positions that we have open and need to fill and contact those individuals as opportunities become available.
Okay, and a related question. Some positions were once considered non-essential and working at home are now considered essential due to workflow of the faculty. I'm not sure I entirely understand that. Can these staff members be allowed back into the office?
Again, I think that goes back to the last question I had, but if you think your need is great, if your leadership think your need is great to be back in the office, I think you have to work that out with your leadership person.
Okay. Thank you, Dee. For the moment, I'll let you step away, and if we could bring Dr. Spollinger back in. Dave, let me know when you're back.
I'm here.
Very good. Let's see here. Has there been any consideration or discussion on pre-procedure COVID testing? Not sure what where the angle on that question.
Well, we implemented pre-procedure COVID testing in order to protect patients who may be in a PACU and next to someone else who is positive, so that we want to know whether somebody is positive or negative, so we can cohort patients. We want to know in order to that we use appropriate PPE in the operating room or where their procedure room, and also we want to know because that if you're positive, you may not be symptomatic, but could be in a couple of days, and it might not be the best time for you to have an operation. So we have been testing everybody who goes through a procedure. I know that it is sometimes challenging to get all that done. And our positivity rate has been under 1%, but it's through abundance of caution and to protect all our workers who are taking care of the patients, as well as other patients who are in the hospital or in the area. Thanks. I don't know if that answers the question. I'm not sure what the question was.
Thank you, Dave. I'm not sure either, but hopefully there'll be follow-up if it hasn't. Two more questions for you. Somebody is asking, did the surgical tower construction, by which I think he or she must mean the new inpatient CIT, did that start back up?
It did not. What you see out there is a campus project. When we were planning the new inpatient tower, there was a need to create also, had been a project on the books that we were going to create a new utility tunnel in connection to Central Campus. And so most of the work that you've seen on that site, or almost all of it, since spring has been related to completion of that utility tunnel.
Another question for you. With community numbers of COVID-19 rising, are there plans to further restrict inpatient visitors or retest inpatients after admission? Currently, inpatients are not retested and risk of exposure to staff doing procedures on these patients.
Well, I think with the rise in COVID, I think we will have to limit visitors. We are trying to make sure that they wear masks, but they're required to wear masks. But I do know that we've seen at times people have been taking off, or visitors have been taking off masks, and we're trying to reinforce the need to do that. I'm not sure, but I see the point, which is, should we be retesting if people come in and are not wearing masks? It would be considered an exposure. The problem is if you get an exposure, you may not test positive for at least 5 days. So not sure how effective that will be. I think the most important thing we do is test to make sure you're negative, and then reinforce our social distancing and mask policy.
Thank you, Dave. I think that's it again for you for the moment. Let me pull Paul Castillo. If you're on, I've got a finance question for you.
I am here.
Very good, thank you. Somebody is asking, or is making the statement and then asking the question, departments in the med school are required to have 75 to 90 days of cash on hand. Why did the health system pursue an unnecessary risky financial strategy of having less than 20 days cash on hand when COVID happened, thus creating an avoidable cash crunch and panic? Was this the advice of the Michigan Medicine Board?
So I'll answer that question in multiple parts. First, I'll give the direct answer. We actually did not pursue a day's cash on hand of 20 days, but I'll come back to that because I suspect I know where that may have come from. In fact, our cash on hand for probably the last several years has been in the range of 150 days to approaching 200 days, sometimes dependent on what's happening in the investment market. And in the late winter, spring of this year, we were at roughly that 150 to 160 day range in any given month. I suspect the reference to 20 days may come from because when we hit the crisis, there were challenges with accessing our broader cash portfolio. One of the things that we kept a close eye on is our short-term days of cash. So short-term meaning, hey, what can we get today if we need it? And we typically manage that portion of the portfolio to 15 to 20 days, but it is a component of the broader 150 to 160 days. So I suspect you may have heard about 20 days, but that was only focused on a portion of the overall cash portfolio.
Good. Thanks, Paul. I appreciate it. I think that's the only directly finance-related question for the moment we have for you. Let's see here. Brian, maybe I could ask you to come on, Dr. Zink. Let me know. Let's see here. The question for you, as part of the family care solution, is there discussion about right-sizing goals and expectations without direct or indirect repercussions during the challenging and difficult time? This is especially true for women who are bearing a larger burden than men.
Yeah, so the last part of that statement is clearly true, and that came out very strongly in the survey when we presented those results and in our focus group discussions that women are totally disproportionately affected by the family care crisis. So that's true. So in terms of changing goals and expectations, I think that has occurred for medical school faculty in terms of the expectations that are set up with the annual evaluations with the chair or with division directors or managers. I don't know as much about that for other staff, but I think that it's really reasonable to look at the effects and the expectations and say that we've been through a really hard time when just kind of getting through the day and the week is sometimes what people can do, and that goals and expectations can be adjusted. On the faculty side, we've have a year extension available for people that are affected by COVID, and we've certainly seen people take advantage of that from the promotion process. But yeah, I think we need to be very open to looking at goals and expectations during this year.
Thank you, Brian. I think that's all I have for you for the moment. Let me turn back, if Dee could come back on. Let me know when you're on, Dee.
I'm on.
Okay. Let's see here. Was there any assessment of the racial ethnic makeup of those who were laid off? Was it the same as the overall health system, or was it equitable?
It was equitable. We looked at the demographics. I don't have those here, but we looked at them as I had mentioned in one of our previous ones. And we looked at the percentage of our demographics for each of the categories to look and see how it fell out with those who were impacted.
Thank you. And another question, will the COVID time bank reset in 2021?
It won't reset, but if you still have COVID PTO hours in your bank, you can use them in 2021. No discussions have occurred with regards to expanding those hours in the bank.
And Dee, I think this is just a confirmation. Somebody's asking to confirm. So for those who are currently working remotely, is the expectation that we will continue to work remotely through March 31st?
At least, yes, that's what we're looking at. And of course, we'll follow what the physicians tell us with regards to COVID and the spread of it.
Okay. Another question for you, Dee, and perhaps you understand better than I do and what this is meant to mean. But the question is, will employees be reclassified in order to show improvements in DE&I metrics?
I don't know what that means. I don't know if Phyllis is clear, but I don't know what that question means. Okay, so if they can provide some more clarification, we might be able to answer it.
Okay, thank you. Let's see, and I think you just answered this, but again, how long will the COVID PTO time be available to employees?
Well, we have not put an end date on it, so it does go into 2021.
Okay, very good. I think that's it again for the moment.
Okay.
1 second here while I try to catch up. All right, let's see here. Dr. Sponger, if you could come back on one more time.
I'm here.
Are there anticipated changes to infection control process with the CDC guidelines about airborne COVID-19 spread?
Well, I think that there haven't been that many changes. I think the CDC still recommends that that we use preferably an N95, which would protect you against airborne spread, and if not available, a an ear loop or surgical mask, which wouldn't necessarily protect you especially in high risk procedures. So I think right now what we're doing is using N95s for anybody who has COVID, and that will continue. We do have enough N95s, at least at the moment, to continue that. The other thing that we've done for COVID rooms is also to use negative pressure and to exhaust the air outside through a HEPA filter. So.
Thank you. Looks like I've got a couple more questions for Dee then again, and I apologize for bouncing in and out like this. Questions are coming in fast and furious, a little bit hard to bundle them.
I'm back on, Keith.
All right, thank you, Dee. Let's see here. Are there any talks of creating a hybrid work option for offsite IT services? Not everyone is happy about working from home and would like to work in office at least 50%.
I think we need to have our leaders take a look at that when we are given the okay to start gradually bringing people back, how we bring them back. Some areas, I agree, may need to come in for a day or 2 days, but I would have to leave that up to the leadership and the department heads to talk about how best to do that and ensure the safety when people come back in, and that is key.
Okay, thank you for that. And another question. Let's see here. Okay, so EFMLA is being used by in-building workers, i.e. Workers that were not working from home. Can you address EFMLA again as far as it pertains to people not allowed to work from home?
Expanded leave time.
EFMLA.
Yeah, if at some time you need to work from home, because we don't know if you're working on site, that bank is still there until the end of the year so that you can use that bank if anything occurs. And it's not just for childcare, it's for if you become ill as well. So it is still there and available.
All right, thank you.
And Keith, while you're looking, can I just say thank you to all of those who are working from home. It can be difficult, and thank you to those who are coming in every day. These are times that we never saw before, but it is time that we come together as a unit and we do what's best for the organization and for the patients that we serve. Thanks.
Okay, and we did get a clarification on the earlier question I had for you about reclassifying employees. I think the individual meant, will some employees be put into management positions so that UM's diversity mirrors the community more closely?
You know, we have an employment process to go through for promotions, redesign, work redesign, and job reclassifications. We would follow our policies and procedures to make sure that happens. And we would make sure we do what our policy says. We just wouldn't reassign someone. We also want to make sure any person who gets reassigned or get into a new position has the skills and ability to be successful, and that's our goal.
Thanks for that follow-up. Another one, are there any plans to increase technology resources for staff and faculty, including providing more laptops, computers, cell phones, or reimbursements for cell phone use? I assume this means at home.
I didn't know if that one was for me, Keith.
Yes, I'm sorry, Dee, if you don't mind taking that one.
Can you read it again?
Yeah. Are there any plans to increase technology resources for staff and faculty, including providing more laptops, computers, cell phones, or reimbursements for cell phone use? And again, I think this is probably meant to refer to people who are working from home and would like greater technology support.
Well, I think we will do what we can as we have to have people continue to work from home, but also as the revenue comes in and our finances look better, we can look and see, because many of you know that discretionary funding was something that we stopped to try to get there. So that's where we are with that. Now, I can't speak specifically on all the details of the technology from HITS, but I do know that if you need services, you can call and see if they can assist you and work with your leadership as well. And we'll do what we can.
Very good. Thank you so much, Dee. I will let you go at this point. And at this point, we have a couple, more than a couple questions for Dr. Runge, and then with just a few minutes left, we can let him wrap up today's town hall. So Marshall, let me know.
I'm on.
All right, thank you. Let's see here. If Michigan medicine is quote unquote on its own with regard to financial issues, that being the reason given for why only our benefits were cut across the university, does the converse hold? If we do really well, can we increase our benefits greater than those provided to the rest of the university?
I'll try to answer that in two parts. First of all, as I said early on, our financial performance has been excellent this year. And I think with that, we have a very good chance of restoring benefits that were lost during the economic recovery process, specifically the retirement match and perhaps other areas. And I hope to be able to report to you on that in about a week. I have not had the discussion about whether we could have enhanced benefits. We do have enhanced benefits in some ways, but it's quite different than the campus. And so I will have discussions on that, and I'll let you know what I find out.
And as you would imagine, there were many questions with regard to the opportunity to restore some of the economic recovery process cuts, including the retirement match.
Let me make a comment about that, Keith. So I appreciate that. I have heard that many, many times. I'm trying to meet with the departments and other groups. And that has come through as, I think, one of our top, if not our top priority. We have a meeting, our quarterly meeting with the UMHS board, which is a week from today. And we'll be presenting a package of potential changes there. And if approved, then they would become implementable. And so as soon as I know that, when I said I hope to let you know in a week or two, I do mean that pretty literally. It won't be next Friday, but shortly thereafter, I'll tell you what we were able to be approved for.
And irrespective of how that decision plays out, is it our intention to restore the retirement match in 2022, if not sooner?
Yes. So the retirement match will absolutely not go on past 2020 for fiscal year 21, which is through next June. But my hope and conviction is that we can restore it well before then.
Very good, thank you. Another question for you. If we are a provider, how do we sign up for COVID surveillance? Or is that only for symptomatic staff?
We have different ways that you can get a COVID test. So the main route is if you have symptoms or an exposure, you can call occupational health and they will refer you for a COVID test, which is done by our own laboratory medicine group. External group developed a surveillance test, which is currently being used on campus. It's just ramping up to full speed. Currently doing 3,000 tests a week, but we'll have the capacity to do many more tests per week. And it's with that group that we hope to be able to make available surveillance testing. Surveillance testing meaning people who have concerns, but they don't have a defined risk factor for having COVID transmission, those being having symptoms or being exposed. So more on that, I think in the next couple of weeks also, as we see how that external effort is going in terms of surveillance testing in the student population, undergraduate student population.
Good. With that, Marshall, we are at the top of the hour. Do you have any closing comments?
I want to just end where I started, which is to thank all of you for everything that you're doing. I can't think of a part of our institution where we're not performing for the care of our patients, for our education of our learners, and for research in really exemplary manners during these very, very difficult, challenging times that I think we will get through this. I don't know exactly the timing, and we have to wait and see what kinds of innovations come forward in terms of vaccines and other approaches. But let me just thank you and look forward to speaking with you again.